Well,
Good evening, sir.
so today we are going to discuss about the management of the carcinoma of cervix here. So the carcinoma usually are the malignancies which are arising from the epithelial origin. So let us have some, before going into the management, let us have some brief discussion about the carcinoma of cervix here. Usually the symptoms are divided into early symptoms or the late symptoms here. The early symptoms are none, usually they present symptomless, but later whenever the patient moves from the carcinoma intraepithelial neoplasia to the invasive carcinoma, the patient usually have white discharge PV, that is white discharge per vaginum, blood bleeding PV, and as well as the bleeding PV usually might be intermenstrual, postcoital, or perimenopausal or postmenopausal usually. So these early symptoms are dependent upon the tumor. The tumor, whenever gets its neovascularization, it starts.
Causes and the risk factors. Usually the risk factor is the main risk factor is the human papilloma virus infection usually. The greater than 90% of all the cervical carcinomas are related with the HPV infection only, mainly of 16 and 18. And
other than it, smoking is an independent risk factor, as well as early age at the coitus and the number of multiple sexual partners, smoking history, and association with the male risk factors is that if the male is having the penile cancer, it increases the risk factors, and that is also a risk factor. Low socioeconomic status, immunocompromised. These are all the causes and the risk factors which are related to the cervical carcinoma. Let us come to the histology of the cervical carcinoma. So 80 to 90% all the cervical carcinomas have the histology of the squamous cell carcinoma, and again they are subdivided into the invasive. The squamous cell carcinomas are subdivided into the invasive, keratinizing, non-keratinizing, and verrucous. And other types are that are rare are adenocarcinoma, endometrioid adenocarcinoma, clear cell adenocarcinoma, adenosquamous carcinoma, adenocystic carcinoma, adenoid basal cell carcinoma, small cell carcinoma, neuroendocrine, and undifferentiated carcinoma. Of all, most commonest histological variant is squamous cell carcinoma. This image, what you are looking is this the junction, the cervical epithelium and all. So the cervical epithelium, whenever it changes to be of malignant and to the cancer type, it will be having the sequence that is cervical intraepithelial neoplasia 1, then 2, then 3, then the invasive carcinomas. Usually, if the infection, usually the HPV infection will be there up to the 2 years. If it is above greater than 2 years and all, and if it is persisting the more and more, then there are the chances of developing the cervical carcinoma 10 to 20 years later. 10 to 20 years of later, having the CIN3, cervical intraepithelial neoplasia 3, or the high-grade squamous intraepithelial lesion by the bedside system and all. After that 10 to 20 years period, then the patient may develop the invasive carcinoma of cervix. Is everyone able to, am I audible to everyone?
Yes.
Now it's crisp and clear, sir. Now you can continue. It's a nice one.
Yeah, I am unable to hear.
Sir, it's clear and crisp now. It's okay. You can continue, sir.
Sir, you are very much audible, sir. You can continue.
Okay. Thank you. And these are now according to bedside system, we have that is atypical squamous cells of unknown significance in the benign cellular changes, as well as the infection in the benign cellular changes, and epithelial cell abnormalities are low grade squamous intraepithelial lesion and high grade squamous intraepithelial lesion, and at last we are having the invasive carcinoma. I have already told you, changing from one high grade squamous intraepithelial lesion to the invasive carcinoma takes about 10 to 20 years. So the patients with the low-grade squamous intraepithelial lesion and the high-grade squamous intraepithelial lesion are the patients who are kept on the follow closely to watch out for the development of the invasive carcinoma. So let us talk about the spread. Where does it can spread? The squamous cell, this carcinoma of cervix. Direct spread. It can go spread into the uterus. It can spread to the. It can go to the vagina, parametrium, bladder, and rectum. That is by the tumor extension. And it can go to the lymphatic channels. That is the primary nodes like the parametrial, paracervical, vesicovaginal, rectovaginal, hypogastric, obturator, and external ileal. Then are the secondary nodes, the common iliac, sacral, vaginal, para-aortic, and the inguinal. Then is the dissemination, how it disseminates from the loco-regional regions to other region. It can disseminate into the other parts of the body. The most common dissemination can happen is to the lung. First is the lung, then it's to the abdomen, then the spine, and then is to the brain. These are a common sites of the dissemination of this carcinoma of cervix. Let us go to the staging of the carcinoma of cervix. Am I audible? My screen.
Yes, sir. Yes, sir.
Everyone able to watch
Everything
my
audible.
screen? Everyone?
Everything audible, sir. Everything audible.
Yeah. So FIGO 2018 staging system is used for the carcinoma of cervix usually. So here we are having the stage-wise management. That is, we have stage 1, stage 2, stage 3, stage 4. Stage 1, stage 2, stage 3, stage 4. Stage 1, the carcinoma, whenever the carcinoma is strictly confined to the cervix, it is the stage 1. In that stage 1, again we are having 1A and 1B. In 1A and 1B, we are having in 1A, 1A1 and 1A2. Here, whenever the stromal invasion is less than or equal to 3 millimeter in the depth, it is taken as 1A1. And if it is called 1A2, then its stromal invasion measures between the 3 and less than or equal to the 5. Whenever an invasive carcinoma is greater than 5 millimeter, deepest invasion is there, greater than that, then it comes into the 1B. And again in 1B, we are having 1B1, 1B2, 1B3. 1B3 is the latestly introduced in the 2018 system, whereas it is not there in the 2009 FIGO classification. So in the 1B1, if we see, if the invasive carcinoma is greater than 5 and less than or equal to 2 centimeters in the greatest dimension, it is 1B1. If it is in 1B2, that is greater than 2 centimeters to the 4 centimeters, it is a 1B2. It is called 1B2. When we call 1B3, the size of the tumor should be greater than 4 centimeters in the greatest dimension. And coming to the stage 2, this is about the stage 1. Let us check here. So you are seeing here 1A1 and 1A2 here. So this is from the old HSCC, but you can see here whenever the depth of invasion is less than 3, it is called 1A1, and when it is 3 to 5 mm, the depth of invasion, as you are seeing in T1A2 here, that is called 1A2. Okay, next coming to the 1B1, 1B2 and 1B3, as you have seen 5 to 2 and 2 to 4 centimeters. 1A1 and 1A2, they are usually diagnosed by the microscopy, and 1B from 1B2 onwards, you can see they are the clinically seen lesions. Let me check here. Yeah. So here 1B1 and 1B2 we can see here. So that is here 1B1 we are having 5 greater than 5 mm to the 2 and 2 to 1b2 is 2 to 4, whereas 1b3 is newly included, that is greater than 4 centimeters. Coming to the stage 2, stage 1 is directly, it is confined strictly to the cervix, and stage 2, it invades beyond the uterus and but has not extended to the lower one third of the vagina or upper two-thirds of the vagina, and it is limited to the upper two-thirds of vagina, not involving lower one-third of vagina, or the tumor doesn't extend up to the lateral wall of pelvis here. So again, the stage 2 is divided into 2A and 2B. The 2A is whenever the tumor is involving upper two-thirds of the vagina. Here you can see 2A1. Here you can see when it is involving upper two-thirds of vagina without no obvious parametrial extension, it is called 2A1, and that tumor dimension should be less than 4 centimeters. Less than 4 centimeters, 2A1. It should be less than 4 centimeters in the greatest dimension. Whereas the 2A2, if we take, it should be greater than 4 centimeter in the dimension. That is, according to size. If the size is less than 4 centimeter, then it is 2A1. If it is greater than 4 centimeter, it is 2A2. Coming to the 2B. 2B is the tumor extending into the parametrium, but not up to the pelvic walls. Okay. 2B is the parametral invasion. So here you can see the tumor extending into the parametrium here from the cervix, as the tumor is extending into the parametrium. In the T2B, you can see that it is extending into the parametrium. That is 2B. Next, coming to the stage 3. Stage 2, we have seen that it invades beyond the uterus here. In stage 3, it involves either the lower one third of vagina or extend to the pelvic wall laterally up to the pelvic wall, or it is causing hydronephrosis, or there is non-functioning kidney, rather than the other causes related to the carcinoma, and it involves the pelvic or para-aortic lymph node. Then it is stage 3. Again, the stage 3 has been divided into 3A, B, and C. 3A is when it involves the lower one third of vagina without no extension up to the pelvic walls. If it is involved up to the pelvic wall, or the patient is having hydronephrosis or non-functioning kidney, unless due to the other cause, then it has been taken as 3B. It should be taken as 3B. Whereas in the 3C is reserved for the pelvic or the para-aortic lymph nodes mets here. If the metastasis occurs to the pelvic lymph nodes, it is known as 3C1. Whereas if it occurs, if it metastasis to the para-aortic lymph nodes, then it is taken as 3C2. So the 3C1, 3C2, 1B3 are newly included in the 2018 FIGO classification. And coming to the stage 4, whenever the carcinoma extends beyond the true pelvis or has involved the mucosa of bladder or rectum and proven by the biopsy, then we can say it has a stage 4 carcinoma. Whereas the stage 4 has again two subtypes, that is 4A and the 4B. 4A is the spread to the adjacent organs like rectum or the bladder, whereas the 4B is spread to the distant organs, that is either the lungs, brain, or spine and all those things and all. So I hope you all have got familiar with the staging system of the carcinoma of the cervix, and let us move to see the management and all. So this is again, these are all slides related to the staging. And 2A2, are you seeing here? The tumor is greater than 4 centimeters here. 3A, are you seeing here? With the involvement of the lower one third of vagina. In the 3A, you can see the lower one third of the vagina is also involved. The tumor is involving. And you can see here 3B, where the tumor is extending up to the lateral pelvic wall. It is extending up to the lateral pelvic wall. The difference between the 2B and the 3B is the 2B just infiltrates into the parametrium, and it may be involved up to the medial one third only. Whereas when if we should call it as 3B, whenever it is called as 3B, it should be extending up to the lateral pelvic walls. And the stage 4, if it invades the mucosa of the rectum or the bladder, it is taken as T4. Whether it can be taken as that is taken as T4A. When the distant metastasis occur to either the brain, lungs, or the spine, it is taken as T4B, stage 4B. So here is how do we manage? The management includes the investigation as well as the treatment. So whenever a biopsy positive comes for the invasive epithelial cancer, either it may be squamous, adenocarcinoma, or adenosquamous, a detailed physical and pelvic examination is done. The pervaginal, perrectal examinations, and with the careful evaluation of the growth of the lesion over the cervix and its extension to the vagina and the parametrial tissues has to be taken detailedly. Then a complete blood count, metabolic panel, kidney function test, liver function test, chest X-ray, and along with the ultrasound abdomen must be taken. Then, depending upon that, either we have to choose the cone biopsy, either the patient should go for the cone biopsy or he is a non-surgical candidate, he must be treated with the chemoradiotherapy. Usually, just to tell in the common, usually the stage 1 and the stage 2 lesions, stage 1 lesions are reserved and the surgery is reserved for these cases. From the stage 2 and all, we have the chemoradiation. From the stage 2, stage 3, stage up to stage 4A, we do chemoradiotherapy for these patients and all. For 4B, either we go for the palliative radiotherapy for the symptomatic meds and all, and if the symptomatic meds are not there, we go for the chemotherapy. Only the chemotherapy is reserved for stage 4B cases. And the radiotherapy along with the chemotherapy for stage 2, stage 3, stage 4 cases, up to stage 4A cases, till it is involving rectum and bladder. Hello?
Yes, sir, you can speak, sir. It's audible now.
Hello, I'm audible?
Yes, sir, you're audible now. You can continue.
Yeah. So now we should consider the cone biopsy and determine the LVI and the tumor size, and consider the PET scanning in the candidates who are surgically feasible, that is in 1A, 1B, and selected cases of the 2A. Whereas from the 1B to 4A, we can go for the optional cystoscopy and the proctoscopy in sometimes, and then CT of the abdomen and the pelvis to characterize the tumor, or optionally MRI. The MRI is better to the CT for tumor extent delineation. It shows better tumor extent delineation, as well as it gives the proper information of the nodes. Note the CT and MRI are equal in the terms of lymph node detection, and the PET CT can add up here. The PET CT shows better delineation of the lymph nodes, better involvement of the lymph nodes can be delineated by the PET CT, or else we can go for the MRI and all. Then, if there is indeterminate or no evidence of the retroperitoneal adenopathy, we can, on the anatomic agent, we can obtain the PET scan to show if any metastasis to the lymph nodes are there. Biopsy confirmation of the suspicious, if the distant metastases are there, then we can see and take the biopsy from those things. But these are all the common investigation. These are all the procedures which are done in the carcinoma of cervix. How we proceed and how do we proceed actually and clearly I will show you later. Okay. So usually this for the stage 1A1, we have simple hysterectomy or the conization here. For stage 1A2 and 1B1, we can go for the radical hysterectomy plus retroperitoneal lymph node dissection. And depending upon that, whether the post-operative radiotherapy should be given or the post-operative chemoradiation should be given is dependent upon the post-operative histopathological examination by a pathologist. After getting that report, we decide whether it should go for post-operative radiotherapy only or post-operative chemotherapy only. If the post-operative radiotherapy is only there, where where it is given is whenever there is large tumor size or deep cervical penetration or lymphovascular. Hello, hello. Now, is everyone able to hear? Hello.
Yes, sir. Yes, sir. You are audible, sir. Continue.
Then in the stage 1A, 2 and 1B1, either we can go for the radical hysterectomy and plus retroperitoneal lymph node dissection, which is much more preferred. The radical hysterectomy plus retroperitoneal lymph node dissection is more preferred. Then we can also go for radiation whenever it is medically not ready and we can't go for the hysterectomy and retroperitoneal lymph node dissection and all, we can pose the case for the radiation with the concurrent chemotherapy. So after the radical hysterectomy and the retroperitoneal lymph node dissection, after coming of the post-op histopathology, we have to decide between whether to go for the post-operative radiotherapy or post-operative chemoradiation. If it has to be posted for chemoradiation, it should have the Peters criteria, that is positive nodes or the positive margins or positive parametry. If 3 are positive, we have to post this case for the post-operative chemotherapy along with the radiotherapy here. If it has to be posted for only the post-operative radiotherapy, it should have the features of the large tumor size, deep cervical penetration or lymphovascular space invasion. And for the stage 1B2, bulky 2A, 2B, 3, 3A, 4B, 3B, 4A, and all from the 2A, 2B, 3A, 3B, 4A, we all take the cases for concurrent chemoradiation here. So the radiotherapy, that is the 50 gray or 250.4 gray in the 25 fractions, 25 to 28 fractions will be delivered along with the chemotherapy, that is 4 to 5 cycles of weekly cisplatin for cervix at the rate of 40 mg per meter square. And the options for the stage 4B disease is the chemotherapy or the palliative chemotherapy. Chemotherapy or the palliative radiotherapy here. The palliative radiotherapy is only given for symptomatic bone mets and pain and all. Whereas the chemotherapy is given to, as it has been distant metastasis, to control the tumor growth more, or else the best supportive care can be provided. And whatever the chemoradiation I have told here, it includes the radiotherapy first along with the chemotherapy. Radiotherapy, we give 50 gray in 25 fractions or 50.4 gray in 28 fractions. Along with the radiotherapy, we are going to give the chemotherapy to the patient within the 4 to 5 cycles. Weekly 1 cycles to the 4 or 5 cycles at the rate of 40 mg per meter square, followed by brachytherapy. That is 21 gray in 3 fractions and all in 3 sittings. That is 7 gray per each brachy. And it
Excuse me, sir.
Hello.
Excuse me, sir. Sorry for the disturbance. Now we have more 10 minutes only.
Okay.
Yes, sir.
So let us see here the broad management here. The surgery we have, one thing is and types of radiotherapy we have to see. Lot of people are familiar, I think, with the surgeries and all, but less people are familiar with the types of the radiotherapy and all. On the right side, we are having the teletherapy, the radiotherapy which is delivered from the external side, and it is also known as external beam radiotherapy. That is, the source and the things are not in contact with the body. Whereas on the left side, we are having the brachytherapy. We insert some instruments and the radioactive source goes inside those instruments and the radiation is delivered there. That is the brachytherapy there. And this is the cast or the mask for the pelvis for the immobilization to place the patient in a single position and all. And let us see what are the types of radiotherapy here. From the evaluation, we have the conventional radiotherapy, 2D planning. We are having 3D planning and the 4-field box technique. We can see here a radiotherapy plan where red, whatever the area is you are seeing. This is the color wash, which is showing that most dose, the most gray, the radiotherapy, the concentrated radiotherapy is present there at the cervix, and less radiation to the other structures. The different types of the techniques, 2D and 3D, and as they are evolving, they are reducing, they are sparing the normal tissues here. These 2D 3Ds are for sparing the normal tissue and to concentrate the more doses of the radiation to the cervix or the disease where it is present. And here we are having IMRT, that is intensity modulated radiotherapy, the latest to the latest techniques and all, using the more amount of the fields. You can see here on 3, 4, 5 fields you are seeing, it is delivering less dose to the normal tissues and more dose is concentrated or deposited near the tumor here, by which the normal tissues can be spared and the tumor tissue will be getting more amount of the dose here. And this is the EPID device which is used for seeing whether the delivery is correct or not. And we are having this brachytherapy machines, that is the 2 types, low dose brachytherapy and high dose brachytherapy systems and all. The intracavitary type we are having, and interstitial type we are having. Intracavitary, they are again Stockholm, Paris, Manchester, and interstitial type of the brachy are Manchester, Quimby, and Paris. And this is the planning, how for the brachytherapy the plans are prepared and all. The palliative radiotherapy and all delivered to the meds, as you can see the meds in the MRI and on the chest X-ray there, and bone scan and the PET CT. This is the chemotherapy, the cisplatin. Usually we give 40 mg per meter square for concurrent chemoradiation. And this is the actual workup here. First, we go with the histophysical examination, complete blood count, cervical biopsy, cone biopsy as indicated, liver function test, renal function test, smoking cessation, as the smoking is one of the independent factor, most independent factor, and as well as cofactor, and HIV testings and cystoscopy or the proctoscopy for another imaging options for considering the fertility sparing and all. Depending upon the stages, the managements are there. And stage 1A, 1 with no lymphovascular invasion, we can go with the cone biopsy and negative margins. With negative margins, if it is there, then it is sufficient. If it is 1A1 with lymphovascular space involvement, and if it is stage 1A2, the cone biopsy with the negative margin is preferred. And stage 1B1, 1B2 we are having, we go for the radical trachelectomy plus pelvic lymph node dissection. These management, either the 1A1 with no lymphovascular space invasion or 1A1 with LVSI and stage 1A2 and 1BB, is for the fertility sparing. When the woman is desiring to get pregnant again, if she has not conceived yet, this is for the fertility options, fertility sparing options. And let us see non-fertility sparing options for the stage 1A1 management. Cone biopsy, if it is negative margins and inoperable, we have to observe it. And if it is negative margin we have taken and it is operable, then it can be posted to the extrafascial hysterectomy. And if it is positive margins, if it has, we can consider for the repeat cone biopsy and to rule out 1A2 or 1B1, and we can directly post for extrafascial or a modified radical hysterectomy plus pelvic lymph node dissection with sentinel lymph node mapping. When it is stage 1A1 with lymphovascular invasion and 1A2, we have to go for the modified radical hysterectomy plus pelvic lymph node dissection, which is preferred rather than pelvic external beam radiotherapy or the brachytherapy. Next, coming to the 1B1 and 1B2 and stage A1, non-fertility sparing options here. We can go for the radical hysterectomy plus pelvic lymph node dissection plus or minus para-aortic lymph node dissection. Or else we can go post it for pelvic EBRT plus brachytherapy plus or minus concurrent cisplatin based chemotherapy. And radical hysterectomy and pelvic lymph node dissection is preferred. That is a category 1 evidence given by the NCCN. And stage 1B3 and stage 2A, we have to definitely post it for pelvic EVRT, that is the category 1 evidence, and that is preferred along with concurrent platinum containing chemotherapy. Either we can use cisplatin or we can use carboplatin there. The cisplatin, if the renal parameters are good, if the renal parameters are not good, as the cisplatin is nephrotoxic drug, it may cause renal toxicities, then we can take it for carboplatin. We can use the drug carboplatin and plus brachytherapy here. Or the radical hysterectomy plus lymph node dissection, or plus or minus para-aortic lymph node dissection can be done. What to do after these surgeries and all, after this hysterectomies and all? If we are having negative nodes, negative margin, and negative parametry, we can observe, or we can give pelvic RT if the risk factors like tumor size, stromal invasion, or lymphovascular space invasion is there. And if the positive pelvic nodes are there, positive surgical margins, or the positive parameter is there, we can go for the metastatic workup. Then we can deliver external beam radiotherapy and concurrent cisplatin based chemotherapy regimens, or plus and minus vaginal brachytherapy can also we can give here. If the para-aortic lymph node are positive, we have to go for the metastatic workup. If negative, for distant metastasis, we can give external field EVRT. If it is positive for the distant metastasis, again we have to prove with the biopsy. If it is negative, then we can go for the external field EVRT. It's nothing but the field is somewhat extended to include the para-aortic lymph nodes here. Whereas if it is positive, we have to go for the systemic therapy. Next, for the stage 1B3, stage 2A, stage 2B3 up to 4A, we have to go for the either radiological imaging or the surgical imaging. If negative adenopathy, we can go for the pelvic EVRT, cisplatin based chemotherapy, along with the post, we can place it for the brachytherapy. Then if it is positive adenopathy, we have to go with the biopsy. Again, we have to see 3C1, again we have to go for the extended pelvic field irradiation if the para-aortic nodes are positive there. If they are pelvic nodes, then we can give the pelvic EVRT. The pelvic EVRT is sufficient there. And surgical staging, negative and positive. If it is negative, then directly we can post it for pelvic EVRT. If it positive, again para-aortic or pelvic we have to see. Para-aortic as their extended field EVRT we can give. And this is not needed now, time is less. This is the if the para-aortics are positive, metastatic disease. If it is positive, negative extended field EVRT. If the para-aortics are negative, then we can give only pelvic EVRT. And the treatment for the therapy or relapse, local regional disease and all. So if we have not given period RT, we can consider for the surgical resection, then we can give EVRT or not. We have to individuate and we have to see whether to give chemotherapy, that is chemotherapy or not, plus and minus brachytherapy also. We can, whether the period RT, prior RT has been given, whether we have to see. So hope everyone is there. So if it is the prior RT we have given, the central disease or non-central disease we have to see. And depending upon that, if it is central disease, we have to go for the pelvic excentrations plus or then if it is a recurrence, then after this also, if it is recurrence, then we have to go for the systemic therapy and all. If in carefully selected patients with the small lesions, we can go for the radical hysterectomy or the brachytherapy. Followed by, if it is again recurrent, then we can go for the systemic therapy or breast supporting care. If it is non-central disease, we can go for again EVRT plus or minus systemic therapy, or we can go for the resection with plus or minus intraoperative radiotherapy. IORT is nothing but the intraoperative radiotherapy, or we can go for the systemic therapy. And if it is recurrent, then we can go for the systemic therapy or breast supportive care. And coming to the stage 4B disease, if it is distant metastatic, if it is, we can give for the local treatment, we can go for the local treatment. Then the local treatment, that is resection either or with the individualized EBRT, we can see the patient. or the local ablative therapies with or without EBRT, individualized EBRT, we can go. Usually the resection plus or minus individualized EBRT is in. If it is not amenable to give the local treatment, then we can go with the systemic therapy or the best supportive care. So these are the types of hysterectomies and the types of the trachelectomies we are having. Simple trachelectomy and radical trachelectomies. The trachelectomies are the fertility sparing options for the carcinoma of cervix, and the hysterectomies are non-fertility sparing options here. So the simple trachelectomy we do in the carcinoma in situ and stage 1A1 when the patient is desiring for fertility again. And radical trachelectomy we have to do in 1A2 to 1B1 in selected 1B2 cases. And coming to the radical hysterectomy, here it is for the local disease without obvious metastasis, including 1B1 to 1B2, and selected cases of 1B3 to 2A1. And modified radical hysterectomy is for the stage 1A1 with lymphovascular space invasion and 1A2. And extrafacial hysterectomy is for only stage 1A1 here. So these are the types of the hysterectomies and the trachelectomy types which are used for the carcinoma of cervix. And these are they are the two types of the exentrations, infralevator and the supralevator exentration types. Next, let us talk about something about the chemotherapy and all. For the chemoradiation, the preferred regimens are the cisplatin and the carboplatin. Cisplatin is more efficacious when compared to the carboplatin and all. The carboplatin is used if the cisplatin is intolerant, that if the renal parameters are not good, we use the carboplatin. But cisplatin is more efficacious. Whenever the disease is recurrent or metastatic, we go for the first line chemotherapy. That is the preferred regimens are cisplatin or the paclitaxel regimen, the carboplatin or the paclitaxel regimen. Other recommended are cisplatin, paclitaxel, and carboplatin, paclitaxel, and topotecan, paclitaxel, topotecan, paclitaxel, cisplatin, topotecan. We can use interchangeably. And first line agent therapy for the recurrent is preferred is cisplatin. Then other are carboplatin and paclitaxel. Whereas second line preferred regimen is pembrolizumab, and other recommended are bevacizumab, albumin-bound, paclitaxel, docetaxel, fluorouracil, gemcitabine, fosfamide, irinotecan, mitomycin, permethrin, topotecan, vinorelbine. Here, you commonly use cisplatin and the paclitaxel for or carboplatin or the paclitaxel for the recurrent and metastatic disease. All over whether to add a chemotherapy drug and all, whether to use another chemotherapy drug depends upon the patient condition and all. If the patient factors, if the patient has some adverse factors or some problems due to which the primary drug or the preferred regimen can't be taken, we have to take the other recommended regimens and all. So in spite of the treatment, let us see the 5-year overall survival. How many people does survive after 5 years? Here? Stage 1A1 after the cone biopsy, simple hysterectomy, and the brachytherapy and all, they survive. Greater than 98% of the patients survive here. Whereas in 1A2, that is if they are posted for the radical hysterectomy plus pelvic lymph node dissection and the radiotherapy and all, the patient usually survive. Greater than 95% of patients survive. If 1B1 and limited to 2A1 radical hysterectomy is performed plus pelvic lymph node dissection, they survive 90%. And larger lesions of 2A1 and 2A2 and 1B2, they are treated as with the chemoradiation. They survive 80 to 85. 2B, chemoradiation is our primary therapy, and overall survival is 70 to 75 patients survive. Whereas third, chemoradiation for the stage 3, the survival is 50. Stage 4A, chemoradiation and selective exentration, 15 to 25%. Stage 4B, chemoradiation with dose escalation we can see, or else systemic therapy, 5 to 15% is overall survival. Stage 4B with the chemotherapy or the palliative therapy, 0% survive patients. So as you can see here, from the stage 1 to stage 4, as the stage is increasing, the 5-year overall survival is decreasing. As the tumor is getting more and more aggressive, it is going to the more and more organs or more and more extent, it is decreasing the 5-year overall survival period. And altogether, the carcinoma of cervix, the 5-year overall survivals are nice, whether while compared to the other carcinomas and all. This is the 4B, that is the spinal mets we can see in this case, and in the brain mets case we can see here the carcinoma of cervix metastasis to the brain here, and that's all. Thank you, everyone. Let us once again review from the starting and all what we have seen. So we have gone with the symptoms of the carcinoma of cervix, that is the early and the late symptoms depending upon the tumor involvement, whatever is there, the symptoms are being there. And the causes we have discussed about the carcinoma of cervix, and we have discussed about the histology of carcinoma of cervix, the most common being the squamous cell carcinoma. Then we have discussed uh, different histological patterns in the carcinoma of cervix, from the pre-invasive lesions and the carcinoma insidious. This is regarding the Bethesda system, and we have discussed the spread, direct, lymphatic, and disseminated spread. Here, one thing we have to note in the dissemination, first is the carcinoma of cervix metastasis, most common metastasis to the lung. This has been most commonly asked in the NEET and the AIM4PG examination. Then the frequency of the metastasis, disseminated metastasis, is to the abdominal organs and spine and the brain. And this we have seen about, we have did about the FIGO classification, that is the staging system. We have went through it, stage 1, stage 2, stage 3, and the stage 4. Though the stages and the managements are confusing, 1 to 2 times a revision or repetition does everything here. You can remind with 1 to 2 repetition everything. So at least the cervix staging is most important whenever a NEET aspirant or the AIMS aspirant is writing his examination. Then we have gone with the staging of the carcinoma. Then we have seen how do we evaluate and what and all we do for a carcinoma of cervix patient. These are the general. We have seen how to manage the management modalities for the stage-wise management modalities we have seen here. And as for any carcinoma, there are the 3 modalities: surgery, radiotherapy, and chemotherapy. Surgery is there, and the radiotherapy, we have seen that teletherapy, brachytherapy, external beam radiotherapy, and brachytherapy, and 2D treatment, 3D treatments, 4D, that is IMRT. How do we plan EPID? We have seen brachytherapy, low dose rate brachytherapy, and high dose rate brachytherapy, and types of the brachytherapy, either the intracavitary and the interstitial brachytherapy types we have seen. And this is about the brachytherapy planning, how we plan a for a patient for the brachytherapy. We see urinary, how much the dose is going to the urinary bladder, and how much the dose is going to the rectum, and then we plan. So basically in the brachytherapy, you can see some applicators over here in the brachytherapy. These are the tubes through which a radioactive source is delivered inside to the cervix, near to the cervix. These tandems and the colpostats are kept adjacent. The colpostats are placed adjacent to the cervix, and within the cervical os, a tandem is placed. So that what happens, whenever the radioactive source goes, goes within the cervical canal and as well as the colposcopy. So the radiotherapy is delivered there. That is the brachytherapy. That is the localized mode of delivery of the radiation. Whereas we are having the teletherapy. In the teletherapy, that is the external beam radiotherapy. We deliver the radiotherapy to the whole pelvis. And here the machine is not in contact. Only the rays come from the up and hit the cells. And about the palliative radiotherapy and all, this is regarding which we give for the symptomatic 4B cases. Whenever there is a spine meds or any bone meds, we deliver the palliative radiotherapy. Palliation is for the symptom relieving. And the chemotherapy, we have another modality that is most commonly for the cervical carcinomas. We give the cisplatin, we have discussed, and initial what are the investigation, what we have to do. We have discussed in detail everything, that is complete blood count, renal function test, liver function test, chest X-rays, imaging, and all other HIV testing, cystoscopy or the proctoscopy, and detailed imaging for to rule out the fertility sparing and options. And according to the stage-wise management, we have seen stage 1 here. In the 1A1, we are having the fertility sparing and non-fertility sparing options. The fertility sparing options, we have seen the bone biopsy with the negative margins. We have to keep the patient in the follow-up. And when it is with the lymphovascular space invasion and 1A2, we have to consider, we have to add up the pelvic lymph node dissection here. In 1B1, we have seen radical rectectomy, pelvic lymph node dissection, and the parotid lymph node dissections. And stage 1A1 with the no LVSI. Here, this is for the non-fertility sparing and all. So depending upon that hysterectomy or modified radical hysterectomy, we have to go. And stage 1A1 with LVSI and stage 1A2, we have seen the modified radical hysterectomy is preferred, or else we can go for the pelvic EVIT also. Then stage 1B1 and 1B2 and 2A1, non-fertility sparing are radical hysterectomy, pelvic lymph node dissection, plus or minus parotid lymph node dissection. For 1B3 and 2A2, definitely pelvic EVIT with cisplatin, chemotherapy, and brachytherapy is preferred. And if the negative, we have nodes, margins, and parameter negative, we can observe, or depending upon risk factors, we can deliver the pelvic EVIT. If there are the positive nodes, positive pelvic margins, or positive parameter, we have to go for the imaging. Then we have to consider it for the external beam radiotherapy with chemotherapy and vaginal brachytherapy. And
Hello, sir.
parotid lymph nodes, we have to prove it by the biopsy. Then if it is positive, then we have to go for the external field EBRT. If it is negative, then we have to go for the if it is negative, then we can deliver only pelvic EBRT only. If the pelvic nodes are positive, we can go for the normal pelvic EBRT. The need of the external beam radiotherapy is only for the if the parotid nodes are positive.
Excuse me, sir. I think Pradeep is having some doubt.
Hello? Yeah.
Sir, what you told about palliative radiation, sir, can you repeat it again?
1 minute. I am unable to get 1 minute. Yeah.
Sir, what you told about palliative radiation?
Yeah. Do you need about the palliative radiotherapy now?
Yes.
See, the palliative radiotherapy is for the pain or the symptom relieving. The patient, palliative radiotherapy is only delivered for the stages of the cases of stage 4B only. What happens in this is stage 4B, we have seen that these metastases to the bone. Let me show you the picture of what happens to me. As you can see in the MRI, on the bone scan and the PET-CT scan, whenever there is a distant metastasis, when the carcinoma of cervix has metastasis to the spine or any other bones or any other organs and all, we go for the palliative radiotherapy here. So the intent of the giving the radiation is to reduce the symptoms here. So if we deliver the radiation to the spine and all, it causes the destruction of the cells, the death of the cells, and reduces the tumor size there and reduces the pain symptoms there. That's why we deliver the palliative radiotherapy. And how much we deliver is usually within the 10 fractions. 10 fraction within the 10 sittings we deliver. That is about the palliative radiotherapy and all. And palliative chemotherapy you are having, that is systemic chemotherapy for stage 4B disease, where nothing can be done. As you see here, the palliative is for symptom pain relieving only. We can't guarantee the patient the cure. Only we can reduce the symptom and we can give the best supportive care in this patient situation. It is for the patient quality, to improve the quality of life, not to improve the survival. The survival benefit we will get from the stage 1 to stage 4A, where we include our management, either the surgery, chemotherapy, and all. Yeah, hope my
Okay, sir. Thank you.
doubt is clear here.
Yes, sir. Yes. Thank you.
So, imaging we have seen. Thing is that it is somewhat elaborated and all. The management is somewhat confusing and all. But when you go with the revision and one thing, then you can get easily everything easily. We have seen about for the relapse disease how we manage, and we have seen stage 4B disease how to manage it, and the types of the hysterectomies where they are used, and the types of the trachelectomies, which are the fertility sparing options. Non-fertility sparing options are hysterectomy types. And exenterations, there are two types of the exenterations which are performed in the stage 4A cases selected. And chemotherapy regimens we have seen here. That is the cisplatin. Only you all just remember the cisplatin for chemotherapy, and also for the most of the head and neck carcinomas also the cisplatin is used. Cisplatin works as the systemic chemotherapy agent as well as the radiosensitizer. What it does is, whenever you give cisplatin, it improves the effect of the radiation, improves the effect of the radiotherapy also. So it is used as radiosensitizer as well as systemic chemotherapy agent to reduce the systemic spread of the cervical carcinoma. And we have seen the 5-year overall survival stage by stage. As the stage increases, the 5-year overall survival will decrease down. And the meds we have seen, for which we give the palliative radiotherapy, and the brain meds for which again we give the palliative radiotherapy and all. These are all for symptom relieving. Thank you all. Hope you have seen this. Yes, now the doubts. Whatever.
Thank you, sir, for such a nice session, and it was very beautiful one because all the slides contained images and details. And students, you can also join sir's Telegram group. I'll be posting the link in the website, and you can all download this video. I'll be uploading. I'll show you where I'll upload in website. I'll be uploading. 1 second.
Thank you, everyone. Hope it was somewhat of the clumsy because of this internet connectivity problem and all. But we have discussed. Hope it may help.
Hello, good evening, sir.
Yeah.
Good evening, sir. This is Dr. Amir, sir.
Yeah.
Yes, sir. The concepts very clear, sir. For clearing, thank you for such a nice session, sir. For clearing all those doubts and all. Today, I think we have dealt more with the radiotherapy aspect, the management. So
Yeah.
it was not that clear for students like us. So thank you for clearing that, sir. Surgical part we were a bit okay, but the radiotherapy part and the other part has been made very clear and very precise, sir. Thank you so much.
Yeah. Yeah, Dr. Amir. Yeah, the thing why I discussed about the radiotherapy and all, mostly the students are unfamiliar with these aspects and all. And the carcinoma of cervix, the most management is dependent upon the radiotherapy and the chemotherapy. rather than on the surgery, as most of the cases present with the stage 2 presentations and stage 3 presentation. We have to go for the radiotherapy and the chemotherapy rather than posting it for the surgeries and all. So the radiotherapy and the chemotherapy is most important factor deciding the 5-year overall survival in these patients. And so I have discussed most part because most of the students and the most of the post MBBS or pre MBBS students are unfamiliar with the radiotherapies, as the radiotherapy departments are not allotted to the most of the medical college. They're not in touch. The students are not in touch with those type of the departments.
Thank you, sir. Hoping to see you again in the next webinars and next session, sir. Thank you so much, sir.
And you can download this video. You can see in the screen that there is Carcinoma of Cervix Management. I will be uploading that by tomorrow. You can download from there. And also for next session, you can go to LearnPad and you can join next session. It is on dermatology. And also sir is having Telegram group where he will be posting all and discussion of all the topics. I'll be posting that link in the video only. So thank you, sir. Thanks a lot for your valuable time for discussing.
Thank you, everyone.
Okay, sir. You
The
can.
next sessions.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you. It was a great session.
Sir, you can stop the recording and we can end the meeting.
Okay, sir. Right. Stop it. Pause.